All right. To our friends on YouTube, you are behind the curtain with Bright Spots in Healthcare's next episode with our esteemed panel of experts. We are going to get started in about 10 seconds, so bear with us. All right, folks. It's showtime. Have fun today. Let's do it. Thank you again in advance. Here we go. Greetings, everyone. This is Eric Glazer. Welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring you leaders to not only inform all of you, but also unearth bright spots, successes at health plans, hospitals, and various other health-related organizations across our country. Our goal is to identify as many bright spots as possible so all of you, the listeners, can determine if the ideas shared on this episode can be applied at your organization. And this is important. We believe this approach, this strategy of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. Our topic today is how to leverage social determinants of health to increase dual eligible penetration. Our sponsor and newest partner in the Bright Spots family is an organization called BeneLynk. They are arguably the most innovative dual advocacy organization in the country. BeneLynk's mission is to improve people's lives and positively impact social determinants of health barriers by granting their healthcare partners with information they need, while also providing healthcare consumers with the advocacy they deserve. I'll give you more details on them later on the show, but you can check them out at BeneLynk.com. I'm going to spell that for you. BeNLY, and like New York, K.com. We have an incredibly esteemed group of experts. Really privileged to have you all here today. Our experts are Lauren Easton. She is the Vice President of Integrative Program Development and Clinical Innovation at Commonwealth Care Alliance. Pam Tropiano, she is the VP of Healthcare Services at Molina Healthcare of Ohio, and Sean Libby, the President of BeneLynk. As usual, we're going to bypass reading all of their bios so that we could spend almost all of our time this hour asking our guests questions and benefiting from all their wisdom and experience as an output of the questions we will be asking them. We'll post a link to their bios in the chat for all of you attending live. And if you're listening to the podcast, we'll post that link in the show description so you can quickly click on it. And I encourage you to, so you can get a sense of all the expert guidance you are about to receive. So let's get started. Oh, one quick PSA, and there'll be a couple of PSAs throughout the show. In about 45 minutes for you attending live, you will receive our regular feedback form. It is the way we get from all of you how we can make this hour each week worth your time. It's why we're covering this topic, dual eligibles, because you asked us to. So I ask you the favor of about 45 minutes checking your email, taking that survey. We'll continue to email you reminders to take that survey until you do. So I thank you in advance. It's really how we are best able to benefit all of you each and every episode. All right, let's start with you now, Sean. Sean Libby, the president of BeneLynk. Let's set the stage. What percentage of Medicare members might qualify for Medicaid, but either they don't know about their eligibility or they've been unsuccessfully able to apply it, and maybe how are health plans helping them successfully apply?
That's great. Thank you for the question, Eric. Thanks for having me, and thanks everybody for tuning in. Yeah, I mean, plans have been trying to do dual eligible advocacy to different degrees of success for decades now, right? Trying to identify Medicare members that are eligible for either full Medicaid or, what we call the Medicare Savings Program, QIMBY, SLIMBY, and QI. And so there have been advocacy programs in place for 20 years to do this. And they've certainly been successful in some regards, but there's still a lot of people that are eligible for these benefits that are not enrolled, right? So full Medicaid, if you look at it, about 40% nationally of the people that are eligible for full Medicaid are not enrolled in it. And if you look at the Medicare savings programs all the way down to the QI1 program, only about 15% of eligible seniors are enrolled in it. So there's this huge swath of people that are eligible for these great benefits, but they're not enrolled in it, right? And we all know why you want to create that dual enrollment. It's great for the member, It means that they get their Part B premium picked up for the state, which is a real meaningful financial impact for members that are at the lower end of the income spectrum. And for the plan, it means you get capitated appropriately, right? So there's an increase in capitation concurrent with providing care to a dual eligible member. So it's a great outcome on both sides. So the question then is, well, why are there still so many people that are eligible? And we tend to think that the answer really comes down to a couple of key things. One, how many people are you talking to? And are you talking to the right people? One sort of group that we tend to think a lot about is low-income individuals in high-income areas. I think traditionally we've done a really good job of doing outreach to low-income zip codes. We haven't done a good job of identifying low-income households in high-income zip codes, right? So I always talk about the fact that there's public assistance housing near me in Greenwich, Connecticut. Traditionally, those people, that person who lives there, they've been ignored in dual eligible outreach. So nobody's talked to them about the benefits they might be eligible for, right? And then when you are doing that outreach, how can you engage people that traditionally have not wanted to engage with dual eligible outreach? And that means taking a different approach than, hey, I think you might qualify for Medicaid, tell me your income and tell me your assets, but more of a relationship-based approach that has more of a human-to-human element.
That's great. Appreciate that. Way to set the stage. So I'm going to bring in Pam Tropiano, who is the VP of Healthcare Services, as I said earlier, at Molina. Before I do that, again, I mentioned earlier about the feedback you all gave us that landed us on this topic. We're also on February 10th, our next live event. We are going to host a live recording on Medicare Advantage and the different approaches, novel approaches to whole person care. And we'll be addressing digital and virtual care, last mile strategies, and how to leverage and amplify the caregiver to drive better outcomes, HEDIS score, star ratings. So if you want to join us for that live recording on February 10th, not going to make you re-register like you did for this one. Sherry Keels, our producer, is going to just put up a poll. Anyone that wants to be registered for that, so they get invited to the live event, registered for the live event, we'll do it for you. So just let us know and we'll do it for you, and you'll be on that list for the February 10th recording. Okay, so Pam, can you provide now, Sean, I think said a really nice kind of set the stage for us. Let's get into examples, bright spots that we like focusing on. Could you provide some examples of SDOH programs that you guys have implemented at Molina that are currently making a tangible impact and improving your dual enrollment rates?
Sure, absolutely. Happy to share those. We have so many that especially, we always focus on, what with our Molina Insights data analytics as we're looking at those, individuals who might be at risk for social determinants, and whether that's food insecurity, housing, whether it's social isolation, we absolutely look at that and try to address it as best as we can. There's three different examples, but the one in particular, we collaborated with the United Way of Cleveland, of Greater Cleveland. And when you think of Ohio, 88 counties, Cuyahoga County, which is Cleveland proper, they have the highest number and highest percentage of food insecure individuals. So we really focused on that. We know nationally that 20% of adults that are over 65, they live alone. Those that are 85, there's 40% that live alone. So social isolation, food insecurity, big problem. And what we now know even better what we did is we collaborated with United Way and other agencies, and we looked at the top 100 of our members who had that attribute for food insecurity and who were just off the charts, going to the ER, having inpatient stays. Their medical expense was really high. So really focusing on the top 100. And then what we did is we did a targeted initiative providing medically tailored home delivered meals for 60 days, 2 meals a day. The response was overwhelming. We had no idea when we looked at those very complex individuals what we were up against. But what we found is that, some of the individuals said that they had no food. They didn't even know how they were going to get their next meal. So really compelling. But what we did then is we looked compared to a year ago, same 100 individuals, and we were just amazed at how the decrease in the medical expense just by intervening for those 60 to 90 days with those meals. So big decrease in their ER visits, big decrease in the inpatient stay. So really good. We're continuing, to work with our med econ team to monitor the savings and to obviously do what's right for these very isolated members. In addition, go ahead.
Can I ask you just a quick question, Pam?
Yeah.
Do you have any, you said great savings. Have you guys gotten to the point where you could?
We have.
Yeah,
we have.
Yeah,
just in the initial, those top 100, we're already seeing over 184,000 to 200,000 in savings as compared to prior year. So as we see that continuing over 6 months, 9 months, our med econ team is calculating that it could be quite significant because these individuals, and when you think of the demographic, they're over 50. They have one or multiple chronic diseases like hypertension, heart failure, diabetes, renal disease, right? Or they can have a combination. So though they're very, very ill and complex living in their home. So we see that savings we already calculated up to 500,000 in savings, even over 6 months to 12 months. So we did partner with Benjamin Rose Institute for those medically tailored meals. So they even got, a meal that was, much more geared toward what they should be having prescribed as a clinically tolerant meal. So that was great. And then one other example is we always, as we're engaging with our members, we always ensure that we can contact them and they can communicate with us. But as you know, throughout the pandemic, there's this big push of, hey, we're going to do video chat, we're going to do telehealth visits, we're going to do all this virtual engagement, which is great. And we think it's great, but the challenge and what we realized very quickly, we did a very targeted initiative looking at all of the health plans across Ohio, got together and said, hey, let's outreach to some individuals and see, do they even have a smartphone? And many hundreds of individuals did not have a smartphone. They had no access to a laptop, computer, or iPad for that matter. And then they also didn't have email addresses. So we did a huge campaign to try to get them and help them get their smartphones. And then again, continue that education to help them engage virtually, which, as Sean, said, and others, that it's really difficult for those that had to get out of the workplace because they don't have that technology experience. So really taking it to another level to educate those that fall into that dual population to have access to emails and equipment and to know how to use them. So we had a really, really great response to that as well. And we're continuing to work on that. One other thing that we did is with the email program, we developed a direct link in our clinical documentation system so that we're able to actually, when we're working with an individual member, and we're engaging with them, we can go into the link, they can tell us their preferred way that they want to communicate with us. And then even there, at that point of contact, we can help them get an email, text with them. So that went very well, and we're continuing those efforts.
Do you have I find the email program so simple, and yet it's the first. I mean, I've heard about smartphone programs before, but not about email programs before. And I'm wondering, do you have any data, like how many emails were you able to, how many people did you train to get on the email? What did that do for overall dual eligible enrollment and penetration?
Yeah. And so I will tell you, in the beginning, the uptick was very slow. And one, word of caution, we had to be very careful about privacy and, working with our legal department and our IT departments to make sure all of it's secure. So the start in the beginning was very slow for communicating with individuals by email, but actually getting them email addresses that they can use globally was great. So in the thousands of members that we were able to help. But again, just a word of caution, make sure that you work with that individual and your infrastructure to make sure it's secure and that it's private in a way that, you're not compromising any private information.
And it sounds like it's a journey, it's a marathon. So you got to grind it out, and eventually the flywheel will get going and you'll start collecting.
Yeah.
Quick up, I always like folks help co-moderating these things. So you have the Q&A module at the bottom of your Zoom interface. Please feel free to jump in and ask folks questions. We'll either write them out to you, answers, or when applicable, I'll interject and add them into the flow of the conversation. So by all means, I'm looking for some help. So feel free to ask your questions as we move along. So I'm going to bring in Lauren Easton, VP President, Vice President of Integrative Program Development and Clinical Innovation at Commonwealth Care Alliance. If you haven't heard of CCA, they are based up here in my hood, up in New England, and they are a non-for-profit integrated care system that deals with complex care and ensures just under 42,000 lives. So Lauren, how are you guys driving dual penetration and growing the overall business right now? Oh.
Thanks, Eric. So yeah, we are in a unique position in Massachusetts as both a payer and provider, and focus on looking at gaps in the system for the most vulnerable members across the state of Massachusetts. We've also extended our services into Rhode Island and have pending approvals in California and Michigan. So we're really excited to be looking at extending our models, our facilities into other states. We have many clinical programs that really meet the needs of the duals and really are able to help grow and sustain our business. I'll start with the crisis stabilization. So our crisis stabilization units were developed when we rolled out our OneCare program. OneCare is the dual program for individuals under the age of 65. We quickly saw a gap in the system in terms of supporting folks in acute psychiatric crisis that tended to go inpatient because there wasn't any other enough capacity of community beds. So crisis stabilization beds in the community. So again, as a payer or provider, we were able to create and innovate two programs in Massachusetts that were really unique, although there are crisis stabilization units in Massachusetts. Our programs were fully integrated medical and psychiatric capacity, where individuals were able to be directly diverted from inpatient level of care, directly admitted from our clinicians in the community, so seamless transition. So we're really helping to support the boarding issues in Massachusetts in the EDs. And really, as we evaluated this program, saw the referrals that we get at our crisis unit are about 88% direct diversions from inpatient level of care, which not only from a quality perspective for this very vulnerable population coming into these programs in a seamless way, getting the services that they need, getting the support they need on our crisis units, we're seeing a large cost differentiation. So folks that are coming in, there's about a 35% lower cost from an inpatient stay.
So with all that infrastructure that's needed to build up and staff and manage those stabilization units, you're still seeing a net 35% reduction, or is that the net ROI, or is that the 35? Does the 35% cost reduction not only subsidize the units, but also there's some extra there?
That's inclusive of all our capital expenses. Wow. And operations.
Wow, yes. So 35% margin. I love that. What about like last mile stuff?
I'm sorry?
Last mile, like what about the health homes, hospital homes? What are you doing there?
Yeah, absolutely. So I think that the other, just in terms, again, of our business, growing our business, thinking about partners, in addition to our crisis stabilization unit, which we also partner with a human service provider to run the day-to-day operations, we have what we define as our health homes. So we partner with folks in the community who have large memberships and have existing relationships with members that may enroll in our dual program, in our One Care program or our Senior Care Option program. So they have existing trusted relationships. The folks that we work with are very difficult at times to engage because of their distrust of the system. So we delegate our care management to these, what we again define as health homes. Many of them are human service providers. Some of them are community health organizations. And so they are working with our members, doing the care management, coordinating services, but also directly collaborating with CCA around a care model and specific care models that we offer to all of our members across the state. In addition, we have what, again, we reference as our hospital to home program, another program, clinical program, where we partner with 4 EDs across the state. We have CCA doctors that partner with the ED doctors to make shared decisions. So when our members are presenting at the emergency room, whether psychiatrically or medically, they're incredibly complex. So many of our folks, the automatic reaction is to have them put inpatient, either psychiatrically or medically, to address those needs. But with the support of both our health outreach workers as well as our doctors that are co-located in the emergency departments, they're able to make shared decisions for alternative resources other than a long, lengthy inpatient stay.
Love that. So if I could summarize the key foundations to, let's say, those last 2 programs working, is this like team of health outreach workers that you guys have trained, developed. Could just quickly for the group, like how do they differ from either your traditional care case manager or your traditional community health worker?
Yeah, so they certainly parallel a traditional community health worker where they will do health education, health outreach, but our health outreach workers really focus on social determinants of health, doing assessments for social determinants of health. They also do psychosocial assessments. They work with our community-based organizations to develop partnerships with our community-based organizations. Many of them are from the communities that they're working in, so they really understand those community resources. So I think that they are also, again, because many, as Pam mentioned, many of our folks are enrolled and we don't have their phone numbers or their email addresses, or they have a wrong address on file. And so much of the work that our health outreach workers are doing are locating, engaging, developing those relationships so that we can wrap all of our interprofessional team services around the member. But the first engagement often will be our health outreach workers. So really key to the success of our model. And they are fully integrated into all of our clinical models and clinical facilities.
So it sounds, if I could summarize, make sure I'm getting this right, because I want the group, they are sort of, if we could use CHWs as the baseline because they're in the community, but they've also got care management skills to integrate, to communicate effectively and collaborate with other practitioners, especially the doctors in the ED. And they're also trained navigators as well. So they're sort of CHW++ in that regard. And that extra training is serving Commonwealth Care Alliance well. It's the key to your program.
Absolutely. Again, I can't highlight enough their ability to develop those trusting relationships where sometimes our members, again, because of experiences in the health system, are distrustful of clinicians or behavioral health clinicians, and that with the relationship that they're able to build, we are then able to wrap those services around the APCs, the doctors, and behavioral health.
And it's your salary health outreach workers that are arriving in the ED and collaborating with those doctors around this. Okay.
Yes.
A shout out to Courtney in the audience. Hopefully that got you the answer. If it didn't, maybe ask it again in the Q&A module. I'm going to bring Pam back in because there is a few questions as a follow-up to the first question I asked you, where you were talking a little bit about your smartphone programs. So I want to just ask a follow-up there, and then we'll keep on going. What resources did you leverage to get these low-income dual eligibles a phone in their hand, assuming it's a smartphone? And did your teams have to assist directly, or did you provide the information to an outsourced resource who did the work?
Actually, we did the work ourselves. So we did, we did the outreach, we helped them, we walked them through, each step. And then we followed up, we made sure that's a big key. We made sure they received the phone, they knew how to use it. So our teams, and again, the team that focused on this was our community connectors. And, during COVID at the highest peak too, many of them were not out in the field, but we just repurposed them to just take on these very targeted SDOH initiatives, which ended up working out great. And then this is now just mainstream part of, all of the clinical team's job, because we know it's so important. And it's not that hard.
How did the phones get funded? By you guys? And
It's actually it's the actual federal smartphone program. So we tap into that. We've also had to do some other innovative things to help people with, those that weren't able to get that type of phone. On our Medicaid side, we did some gift cards, some incentives just to help people be able to even pay their phone bills. Some of the larger carriers offer some programs that you can actually get debit cards or gift cards to help people, which we did for a while as well. So just really looking at what is the pulse and what's needed out there to help individuals.
Great. And heading back to you real quick, Lauren, as a follow-up, and then we're going to move on to the next question, Sean, warm up, is those health outreach workers that were in the ED, I know they're physically coming to the ED. Could you help the group explain how do you cue them to arrive in the ED? It's not like they're sitting there in the lounge all day. So just a process there for the group to understand how you get those healthcare workers, health outreach workers physically at the emergency department.
Sure. And just to be clear, Eric, our health outreach workers are not only in the EDs, but they're also really focused on working with folks in the community, meeting people where they're at, whether that might be at a shelter, under a bridge, at a Dunkin' Donuts. So they work, primarily in the community, but as well in our ADs. But in terms of getting them to the EDs, we utilize patient ping to be notified when our members do, as a payer, when our members hit the ED. And so both the doctors and the health outreach workers are notified through that system to understand when our patients are there. So the doctor in the ED may consult over the phone. However, with our health outreach workers, it is very often very important for them to come face-to-face into the ED to meet with those patients. So again, if it's a quick consultation with the doctor, it certainly can be done over the phone, but they're located close enough by when a patient does hit the ED, they will go and see that patient in person. Really, again, very important for them to be able to meet that person face-to-face.
Fantastic. Well, let's talk now about some tactics to get us above the benchmark. So typically, Sean, as I understand it, Medicare plans, 10% maybe are dual eligible, and maybe an average dual eligible advocacy program that's implemented by a plan gets them to, let's say, 12% over 18 months. So 1 to 2% increase. How do you double that? How do you get to like 14%? Like, what are the key things that the plans out there that are doing closer to 4% increase? What are they doing differently?
Yeah, it's really interesting. It was great just listening to both Pam and Lauren talk, because so much of sort of the themes of what they're talking about kind of resonate with the work that we try to do and that we see successful plans do. I think a foundational element to remember is that the dual eligible population is fundamentally a lot like the dual enrolled population. They don't have Medicaid, but they have the same sort of SDOH barriers, and they have the same sort of health profile overall, right? So that means that they need the same services. And it also means that if you're looking to find people that are eligible for, but not enrolled in dual benefits, serving their SDOH needs is a great way to start that conversation. Right. So one thing Lauren said is building trust is necessary. And we think that's really important. And how do you do that? You start with a real human to human connection that starts with saying, hey, what's going on in your life and how can we make things better? And we absolutely agree about the idea of sort of hiring from the communities you serve. It's a great way to sort of start with that start building that trusted relationship. And, Pam talked about, food insecurity, which is absolutely an area that we address all the time. So if you look at a theoretical population, they're not dual enrolled, but they're dual eligible. You find somebody who's food insecure. So first of all, what you realize when you try to engage them to get them in Medicaid is you realize that they might be focused on more short-term needs. If somebody doesn't have their next meal planned, the thought of doing a long-term process to get onto Medicaid is a high bar, right? So that's where we get in this concept of what we call leading with help, right? Where we try to meet the member where they are. So understand, okay, what's the challenge you're worried about? Food insecurity. All right, let's address that on a short term and on a midterm. So in the short term, what we would like to do is we're going to identify a food pantry right down the street from you, get you the information, get you the hours, let you know how you can, what your eligibility is there so that you can address this hopefully today. Then let's look at the midterm, right? Let's see if you're eligible for SNAP benefits. We're big fans of SNAP benefits. They're underutilized. Again, to talk in terms of take-up rates, only about half the eligible population nationally is enrolled in SNAP or EBT benefits. So it's a great program, really can impact people's lives. So as a midterm solution, after you sort of solve the most immediate problem, get them enrolled in SNAP benefits. It's going to be a more durable way to address food insecurity. And then once you've done that, once you've sort of met the member where they are and you've solved their most immediate challenge, you've accomplished a couple of things. One, you can be building some trust, right? Because they see that you're working with them. But two, now you have the opportunity to sort of open up the discussion to say, okay, now let's talk about other things that we can do for you long-term. You might be eligible for a Medicaid program. You might be eligible for one of the MSPs. We can get your Part B premium paid. So let's see if we can open up the conversation about that application now. Right. So there's just a subset of the population in Medicare that is eligible for and has always been eligible for these programs. But if you don't sort of take the conversation from a different direction, if you're not sort of leading with humanity first and meeting the challenges of the member, they're not going to engage with you, right? So they're going to remain dual eligible, but not dual enrolled. So it's really about saying, okay, how do you take all of these things that I think both Pam and Lauren are talking about and apply them not just to the dual enrolled population, which is great, but also the dual eligible population, give them that same type of help, and then use that as a way to say, okay, let's help you become dual enrolled. When you do that, right, that gives you the opportunity to, coupled with reaching a wider population, you're starting to just bring in more people in to the process, to the application. And that's the key, right? There's only so many levers you can pull here. You want to make sure you talk to more people. You want to make sure you engage more of the people that you talk to in a meaningful conversation. And then finally, you want to make sure that when you do submit that Medicaid application or that MSP application, that you're really all over it to make sure that if they're eligible, they're getting enrolled. And just to throw out an example that we've seen lately, the pandemic payments that have come out from the federal government. By law, those are to be disregarded when you're looking at Medicaid or MSP applications. In practice, we've seen they're not getting disregarded properly over and over again. So you see a member who's eligible not become enrolled because it's a confusing time, right? There's a check coming out from the federal government, and the state agency doesn't necessarily have the processes in place to disregard it, right? So you want to really be attacking it on all of those levels of, how do you talk to more people? How do you build more trust with those people? And then once you've done it, what are you doing to make sure that every application that can get approved does?
It's great, Sean. So I'm gonna keep you on, and Lauren. Well, Lauren mentioned earlier that health outreach workers are sort of a key foundational component to building a successful program for real true success. And so it strikes me to accomplish everything that you just mentioned, you need to build a successful outreach team. So how do you, one, build a successful outreach team that can accomplish everything you just mentioned? And then how do you enable them to be successful, or better put, maybe how do you create a scalable program with human beings in this role that they're constantly providing high quality outreach and engagement, as you just talked about, leading with help, et cetera?
Yeah. I mean, I think you use the key word, right, that we focus a lot on, which is human. I think that whenever you're having these types of interactions, I think there's a place in our industry for IVRs, for all sorts of communication. But we really fundamentally believe in the value of a human being speaking to another human being. And now that is primarily over the phone. So when we're looking at who we're going to, get to do that, who are we going to, have join our team, we look for people that are good at making that human connection. We don't recruit based on their understanding of SDOH programs, on the basis of Medicaid programs, right? Instead, we're looking for individuals who have that ability to make a human-to-human connection with the person they're going to serve. And then we look at it, it's our technology's job to be there constantly giving that person the answer that they need. So we designed our technology in a way to say, when you're on the conversation, if it goes in this direction, okay, now this person has said they're food insecure, to go back to that example. All right, let's surface the food pantries right away so you know where they are. Let's surface the SNAP application so you can go in that direction, so you can respond to what you're hearing. I think there's nothing worse. We've all experienced it over the phone, than being sort of locked into, somebody saying, I want to go down this series of steps, and they're not kind of responding to you. So what we really want is that team that has that ability to say, I'm going to make a human-to-human connection. We're going to focus on people that's their skill set, and then use technology to support them.
So I'm dating myself here, but as you're talking, I'm envisioning sort of your outreach team having almost this platform in front of them that's like choose your own adventure. And as the conversation's going, they're clicking in data, and then the system's allowing them to go down that adventure and give them a script for each direction that the member on the other side of the call is taking them.
That's right. That's what allows you to sort of meet the member where they are, right? If a member is concerned with one particular thing, it's like, it's just blaring in their head. And that's what they need. You need to address that first, or the conversation can't sort of go on to that next level, right? So you want that ability to do what a human being sort of naturally wants to do in conversation with another. Let's talk about what's going on first for you, and then we can sort of pivot the conversation organically.
So what I like about that from a scalable situation, and I'll summarize and just confirm this for me, and then I'm going to move on to a follow-up question for Pam. You need to have really good recruiting, really good training, but you also have a technology platform that makes this scalable so that your outreach workers or your call center folks don't need to be great at everything, because they've got technology to assist them to be great at everything.
Yeah, I mean, it's a very competitive labor market out there, right? So everybody knows that. So, you can address that how you do. I mean, we certainly look to how can we be more than competitive in wages and everything else, so that when we get somebody who's good at this, they stick around and stay with it. But I think you're exactly right, Eric. You can't get somebody who can do everything. So the question is, what do you prioritize when you're hiring? And then how do you supplement that through training and through technology?
Okay. So Pam, when we're talking about like the foundational components for successful programs, we've got Commonwealth Care Alliance talking about health outreach workers, which is a little bit of a different spin and bent on traditional CHWs. We've got BeneLynk talking about the combination of human touch with technology for scale. What about benefits integration? I mean, I know like there's a lot that has to happen behind the scenes to have a successful dual eligible program. Talk to me a little bit about what you guys are doing in Ohio on benefits integration.
Right. So for all of our dual members, they are similarly, as Sean and Lauren have described, they're all, we have a care manager assigned to each and every one of them, because we know the human touch is important. And, we've got that infrastructure as well, locator teams, all of that. But more importantly, when we're engaging with the individuals, and again, partnering with them, making sure that, we're figuring out what is it that they need. If they don't have housing, if they don't have food, transportation is huge, all of those, I call it the top 10 list that we go through all the time to make sure none of these individuals who are often very chronically ill, none of them are going to be able to, they don't want to hear about what they need to do with their diabetes or their hypertension, because they don't know where they're going to live, or they don't know even how they can get to their appointment. So with that, that care manager has a system, and at his or her fingertips knows these are the benefits that you have that we can provide. This is the help that we can provide, and we're going to do it in a really proactive and very efficient way. It's only me. I'm working with you. Here's what we're going to start with. Get that, in the health insurance space, it's all about what's a covered benefit, what's allowed, how do we get it authorized really quickly and in the system in a very expedient way, which we have done. And believe me, over the years, it has improved greatly. We went, even very recently, went from a very manual system that was cumbersome, was not good. We have partners on our dual side. We work very closely by contract with the area agencies on aging across the state, and they're great. They provide that service coordination. We, collaborate with them, but we also know that switching from a manual system to an automated system is not an easy task. So we did that in the long run, it's helping get those authorizations and that information into that individualized care plan or service plan, so that the member, their family, the care providers, they all have access to that quickly, and they know what they have authorized. The problem is, getting into sometimes that automation for, end users. You've got to be patient. You've got to train them. The most important thing is listening to the feedback, right? If you implement a streamlined authorization system, which we did, integrating it, the auths, the care coordination, we integrated the whole thing. That's all great as long as it works and it gets that individual member and their family what they need. And it does work, but have your end users, if you're switching systems from a manual to an automated system, have them be part of the solution. Like the areas on aging, their workers, they gave us feedback and we listened, and things that just made no sense as we were transitioning that system, we took that in, we made tweaks along the way. So those are just some lessons learned. But again, currently, right now, it's fully integrated, it's intuitive, and that information with the care manager at the helm, the individual member and the families know what their benefits are and what's on that treatment plan, which is great.
Let me summarize. So you have to make it intuitive. You need to link the systems together. Manuals just takes too much time to be really effective here. You need to have your care managers and the people who are using the system involved in the development and the acceptance of the system. For those of you UX folks, that's called UAT, user acceptance testing. So those are all the learnings. And then just real quick, it sounds like a pretty complicated integration. What was the tool or software that you guys used to make this all happen?
Yeah, so we use the PEGA system. So we have that we use for authorizations, and it's accessed right in our clinical documentation system, which is great. So they're not in a precursor system. It's right there. It's right in that system, and it talks to every other area. So you don't have to go off and do any kind of I have to email you this template. I've got to, transfer you this shell of a care plan. It's all right there in the system, which is great.
Okay, that's great. I want to get into two things, folks. My panel, if I could ask you to look at the Q&A module and address the primary language, maybe via just typing it in, just to save us time. We're running a little bit behind. Ask you to favor to do that. I want to get into the public health emergency, PHE, and what the impact of that is going to be once it goes away. So that's going to be our next topic, because I know it's an important one for everyone in the audience. Before we go there, I promised everyone I was going to tell you a little bit more about our friends at BeneLynk. We can't put together programs like this each and every week for you without funding from sponsors. Now, the great news is, thanks to all of you and all the support we have garnered over the last 8+ years now, we could be a little bit choosy about who we quote unquote take our money from. We choose partners that could provide not only financial support to our programming, but also expertise and content support to the programming that we know is going to be most interested to all of you. And so we're just super excited that BeneLynk is now part of our family. They are a national provider of social determinant of health solutions for both Medicare Advantage and Managed Medicaid health plans. And they serve plans and their members by creating, as Sean mentioned earlier, this human-to-human connection and providing the assistance a member needs to get to all the benefits they deserve. Sean mentioned that technology and human touch, which has been really effective. Their team is able to help Medicaid members to retain their benefits through a comprehensive outreach campaign, providing information and assistance, leveraging SDOH to get to that. All of their services are customized to that specific geography and provide members with specific information they need to keep all of their benefits in place. So like I said, I get to talk to a lot of companies in this space in my role for this podcast, and believe that BeneLynk is truly changing the way the healthcare industry communicates and builds relationships with consumers with complex healthcare conditions. I do believe they are a bright spot in our industry, and I encourage you to connect with them. Sean's available to you, and in the feedback form, you could reach out. I'm happy to make a personal introduction to him, but I'll ask Sherry Kesley-Crichton, who heads their business development, and Sean are both available to you via email. You can informally pick their brain and get some of the insights they have access to. Don't necessarily have to hire them, but they're really interested in just networking and trying to provide as much value as they can. So Sherry will put their emails in the chat if you want to reach out to them. But like I said, I'll make a warm introduction to anyone that wants to. You can request that through the feedback form. So let's get now to the topic, dual eligibles and the PHE. So I know it's a huge challenge to enroll these folks and make sure that they know they're indeed eligible for benefits. And I've recently read that once the pandemic is over and we have to start these redeterminations, health plans on average are going to lose about 5% of their eligible members, which is going to be a huge impact on their revenue and on their overall market share. How are all of you planning on to manage redeterminations once the public health emergency is behind us? I'll start with Lauren, Pam, then I'll go with you, and then Sean will finish off. Lauren, you are on mute.
Yeah, thanks, Eric. So CCA has significant outreach across the state of Massachusetts with our enrollment teams, with our care partners, that we're reaching individuals, reaching folks that are eligible for dual eligible but not enrolled. But also with our current members, encouraging them, educating them about documents, educating about things to look for in the mail, redetermination. But we really support our members on a one-to-one basis so that we're, again, helping them to monitor what the extent of documentation that may be needed. In addition, our community partners are really important in this process, where they also are working with our members, whether, again, it's a human service provider, a community health center, CBOs that are working with our members directly and supporting them to ensure that they are retaining their enrollment in CCA. And in addition to that, looking for folks that are dual eligible but not enrolled for their ability to enroll with CCA. Helping them to understand what the benefits are, how the benefits differ from other programs or just Medicaid, Medicare.
You know, it strikes me, as we think about the pandemic right now, and I know we're talking about like post-pandemic, but as we're talking about it right now, I know the pandemic in general has created just this larger pool of consumers who are dual eligible, seniors who can't work from home because they were in an office or at a store, and they had this income that put them over Medicaid, and now they have to stay at home or quit their jobs because they're not tech savvy enough to work from home. So there's now these new dual eligibles who were previously not eligible for Medicaid. So Sean, I know Sean Libby recently authored this one pager on this topic and how to think about that. So I was looking at it as we were preparing for this show. So anyone that just wants a copy of that, we'll include it in our follow-up email to all of you. Let me know. It's a PDF. It's a one pager. It's a good, easy read. I'll have Sherry put up a poll. If you guys want a copy of that, happy to send it out to you. Pam, what about now, just moving back to the PHE, how is Molina thinking about redeterminations once the PHE is over?
right? So, and similarly to what Lauren shared, we've got a similar process. It's just for the duals, just making sure once we get that guidance, just proactively getting out there, engaging with individuals. They all have, it's part of the mainstream of what we offer and educate on all the time. So it's absolutely part of the process. So just, making sure everyone understands how they, reminders and education on what to do. So we really hit that hard. On the flip side, with our Medicaid members, we also address this, and we also, work across our teams cross-functionally to identify any Medicaid members who, as we're working with them, over time we feel they would qualify for dual programs. So we do it both ways in assisting them.
And Sean, like now raising it up, like thinking strategically as a CEO of a health plan, how, I think it's, Molina CCA, they seem to be in a position where their infrastructure is such where they feel they're in well positioned for whatever the government throws at them from a PHE, when the PHE ends. How would you think about it strategically? How would you think about what you could do now with confidence, what you could prepare for, because there's an unknown here on what some of the new rules of engagement are going to be?
Yeah, it's really tricky, particularly if you think about it from a multi-state level, because you're really dealing with multiple governments, right? So when the PHE, was started, states had some choices. What they could not do was remove people from the Medicaid rolls with very, very limited exceptions. So some states chose to continue their annual renewal processes, but just hold in abeyance any removal from the rolls. And those states have been continuing their communications out to members and asking them to go through the same process. Some states stopped the recertification process altogether, right? And they said, well, if we can't remove people, we're going to, take the administrative savings, we're going to stop recertification. And then some states have done a combination of one or the other. So the first question sort of is, all right, well, what has your state done? Has there been a recertification process that's been done that some of your members didn't comply with, right? And in other words, they're on a list where they're going to lose benefits, or they're in danger, I should say, of losing benefits when the PHE ends. And that leads to sort of the next question, which is like communication with the state agency, right? What we've heard plans are doing is doing a couple of really smart things. One is asking the states, hey, can you tell us which of our members are out of compliance so that we can put in place a remediation plan? I think they're meeting with some receptivity from some states relative to that. I don't know that we've formally heard of a state saying, yes, I'm going to do that, but it seems like the state agencies are interested in sort of pursuing that. Pursuing that option, right? And similarly, there's an opportunity to say, okay, for people who have lost that eligibility in that period, can we now move them over to an exchange plan to make sure that they have uninterrupted care? So, right, so those are kind of the dialogues that we see plans having with state agencies, and we think, that's really smart. And then, beyond that, really what you can be doing at this point is you got to plan for both the known and the unknown. And that's challenging. I mean, I think there was a model of what the PHE wind down would look like in Build Back Better. The future of Build Back Better is unknown at this point. It's perhaps a template that you might look at. But what I think we know that plans are doing that are in preparation for this, you got to build capacity because it looks like there's going to be some time crunches where a significant amount of members, maybe 1/12 of the population, maybe another group of the population, will need to be contacted in a relatively short period of time to engage them, right? So how can you plan to have that capacity? How can you do scripting and letters and everything else like that, right? For messages specific to the end of the public health emergency, so that you're sort of speaking to this specific situation. And that specific scripting, we always think it's so basic, but it's so important. If you're talking to somebody in, Massachusetts, you want to say Mass Health, you're talking about somebody in Wisconsin, you want to talk about Badger Care, you always want to make sure that you're speaking speaking to the person as specifically as you can about the situation they're in. And in the case of the PHE, be speaking to them specifically about what the end of the PHE means to them. So it's a challenge, right? But I think the things I would point to is dialogue with the state's going to be positive, and really building a plan for what we know, and then a little bit of a plan for what we don't know yet.
That's great. Thank you for that. I know we're cutting close on time. Our producer, Sherry Kills, will shoot me if I don't remind everyone that that survey is now in your inbox and you should take it now. I'm going to rattle off some really interesting questions from the audience right now, and we'll see what we could do to knock off a couple here in the last 5 minutes. I first want, let's start with SDOH partnerships. So there's a lot of different vendors or community centers out there, food banks out there. How are the health plans approaching these types of organizations who may not be experienced in payer contracting and may not be compliant with Medicare or Medicaid? Pam, I'll start with you.
Yeah, actually, we experience these types of situations and relationships all the time. So anything that when we identify a need, we just work with that agency or the community-based organization, and we work it out. Our process internally is not that cumbersome, but we definitely have a template check boxes that we gotta make sure that we adhere to. But I personally bring it back to our procurement office, our network team. We work through it. If it involves, if it's a service, it's very simple. We've got, other food pantries we've worked with in other areas of the state where we put things in place with little debit cards that can be used at food pantries, things like that. Expansion of mom's meals across the entire state, not just, with our initiative up north in Cleveland. So we do those things all the time. The only time it gets a little tricky is when there's any kind of, IT or any kind of secure information that has to be exchanged. So anytime that happens, it's a little bit harder, but for the most part, in those just providing a service and giving, extra benefits, it's very simple.
Okay, great. I'm going to grab another one. I will ask Lauren this. Lauren, you may just have to pass on it. You let me know. So someone's asking, there are a lot of SDOH metrics out there. Some are free and some are proprietary. Any thoughts on some of the most trustworthy, up-to-date social determinants of health resources or sources?
May have to pass on that one.
Okay. Anyone else? Well, I'll give it up for a jump on. If we can't answer it, we can't answer it.
Right. We actually do have some recent references and resources that we did pull prior to this podcast. So I have a list of them that I'd be happy to share.
Okay. Why don't we, Sherry, we'll include that in the follow-up email with the recording to this esteemed group who's joined us today. All right. I'm trying to do some really good questions here. I just want to make sure that I'm not going down a rabbit's hole. We run out of time. How do you track community organizations' referrals to social services? Anyone could answer that. How the referrals from community organizations over to social services?
So I can take that one. We actually use a service called Aunt Bertha. So we do use that. So we use Aunt Bertha, and not only throughout the regions to find resources, but also to make sure you can track the referrals and make sure that you can get reporting on that as well. And it's actually a great system. And prior to using Aunt Bertha, we created our own internal resource guide, but it was so cumbersome to keep up. So that was the best solution for us, and it works great.
That's great. For the health plan friends here, so I'll start with you, Lauren, and then go to Pam. What EMR do you utilize?
We're currently using eClinicalWorks. And we also have a care management platform, which is Altruista.
Great. Pam?
We use for clinical, we use Clinical Care Advance.
Okay. Awesome. All right. I'm going to hold off there. There's not a whole lot of more questions I could get into in the remaining time we have. I want to thank everyone who took the hour to join us. I know you were busy. I know this is, I don't take for granted for once that you carved out an hour to listen to the show live, or if you're on a walk or in the car or in the airport right now, listening to the podcast. Really appreciate you trusting us with all the time. I hope you got a lot of value from this. Please fill out that feedback form. If you're listening to the recording, you can email me at eglazer@sharedpurposeconnect.com. On other topics that we could provide to better serve you, you could certainly provide me constructive criticism on this show in particular. I'm open to all of it. It's how we've been able to survive, thrive, and grow over the last 8 years doing this show. So I really appreciate everyone's participation, and a special thank you to Pam, Lauren, and Sean, who spent a lot of time with me preparing for this conversation, and then the hour here in the middle of the day to serve everyone in the audience. I really appreciate it. Thank you very much. This will mark the end of the show. We look forward to seeing you on our next live recording on February 10th. If you have not subscribed to the podcast, Bright Spots in Healthcare, wherever you listen to podcasts, we're there. Type in Bright Spots in Healthcare, press subscribe. This is your podcast to learn from others and benchmark and hopefully clone to make healthcare better for everyone across this country.